It's an honor to be here, and I'm really grateful for the opportunity for Tom. And as he said, we've known each other for a long time, and I just admire the work that you guys do here at Rams in Recovery and VCU in general. So I wanted to just, first of all, just introduce myself a little bit, how I got here. I'm a person in long-term recovery, and things have sort of led up to this point. I just finished writing a book, so I'm sort of excited about that. But bottom line is I grew up in New Zealand, and I always wanted to be a doctor. We had a great family doctor growing up, and I just really liked the way it looked for him practicing medicine, and so I went to medical school there. And while I was there in my second year, I had 3 friends who said, "Do you want to come to America and go skiing and work at a ski resort in California?" So this was 1975, and I was 19, and I thought it couldn't be better than that. So I came over here, and I just fell in love with this country. And I thought, once I get through with med school, I'm going to come back and start working here. So that's what I did. By the time I came here, my addiction was really already in full-blown form. I didn't really realize it at the time, but you know, the bottom line is I grew up in an alcoholic family, which I didn't realize until I got into rehab. But the first time I ever drank and got drunk with cherry brandy from my neighbor, he stole it from his brother, I just absolutely fell in love with that feeling. I just loved how good I felt, how exciting it was, how it almost opened up a new world. The first time I got really high with pot, I was like, this is unbelievable. I love this. I'm going to keep doing it. But I was throwing up with that alcohol and felt totally like crap, so I thought I need to be smart enough to figure out how to control it. And so I thought I was in control of that, but you know, negative consequences, you know, kept appearing. I got arrested and put in jail at one point. I got a DUI, but I kept getting off of everything. But I loved that feeling. I loved getting high. I loved pushing things to the limit. And by the time I came to America, I'd already tried injecting morphine from my doctor's bag because I had a girlfriend who, she said she was an ex-heroin addict, so we should try a little bit of morphine, which seemed like a good idea to me. And cocaine was, this was 1983 when I moved to America, and cocaine was kind of a really big thing. But I loved that excitement, and I sort of felt a little bit like Odysseus. I don't know if everybody knows the story of the Odyssey, and there's a big movie coming out just in a couple of months about that. And I don't mean Odysseus, the big, strong, handsome guy who's an amazing fighter. I mean Odysseus who wanted to visit the sirens and go past the sirens. And I don't know if you all know that story, but the bottom line is, the sirens were these absolutely gorgeous women who lived on this island and sang the sweetest song that no human, no man could ever resist. And Odysseus, and of course, the island was wrecked with shipwrecks of all the sailors who had been lured into this island. And Odysseus said to himself, well, I want to experience that. I want to feel that call. I want to feel that excitement. So he had the men tie him to a mast while all of his people rowing the boat put wax in their ears so they couldn't hear the song. And he said, row me as close as you possibly can to that island. I want to feel that. I want to experience that. And he did, and he got away with it. I'm like, that is one of the best addiction stories I've ever heard. But that's kind of the way it felt to me. By the time I came here, I started working in a family practice residency program in Blackstone, Virginia. And by then, I was already using quite a lot of cocaine and alcohol drinking and injecting opiates when I could get away with it. And then actually a friend from New Zealand smuggled in a kilogram of cocaine from South America, and he had no one to give it to, so he said, will you take it off my hands for $1,000? And I was like, what could go wrong? So I did, and I just lost control, and I just was using all the time, and the bottom line is I ended up having a drug overdose and turned blue and stopped breathing. And fortunately, a lady that a nurse that I was having a relationship with had a key to the office where I'd gone down to the medical clinic, and she called the doctors, and they gave me Narcan and resuscitated me and brought me back to life. And said, you need to go to treatment. And I tried arguing with them. I said, that's ridiculous. I don't have a drug problem. How could you possibly think such a thing? They said, well, if you don't go, you'll never work as a doctor again. And so that got my attention, and I went to a rehab, actually, with what's now become the Farley Center. But back then it was the Virginia Impaired Physicians Program in Hampton, Virginia. It was a 4-month program. And I started learning about what addiction really was. Dr. David Fluharty gave lectures on how the brain gets affected by drugs and how the genetics work. And it made sense to me, and I suddenly realized my mom was an alcoholic. It had never really crossed my mind. I knew she drank too much, and I knew she'd gotten in fights with my dad, and it was really painful growing up. And I knew she got hooked on sleeping pills, and I knew in medical school I was always trying to find the new sedative, the new sleeping pill that would be a little bit easier for her and not make her look slurring her words so much and get in trouble. But I didn't put 2 and 2 together that was alcoholism or that was addiction. And I didn't realize my brother was an alcoholic. I just knew he was mean and nasty and would always fight with me and punch me in the arm. And I knew my uncle was an alcoholic, and his daughter ended up dying of a suicide. So it became clear that there was a strong family history for me, and I started relating to that and realizing that I did actually have this disease. I started looking at my negative consequences and stuff. And so, fortunately, part of my rehab for 3 months, I had to work in the field of detox. So part of our treatment was to work what was called mirror image therapy. And my job was every morning I would work with Dr. Holt, detoxing patients as they came into the hospital. And Dr. Holt was a recovering family practice doctor from Petersburg, and he was just the most amazing man that I could be around. He was so happy. The nurses loved him, the patients loved him, and he just loved doing what he was doing. And he told me his story, and we shared things, and he would call me Kiwi, because that's what people from New Zealand, he'd say, come on, Kiwi, let's go see the next patient. And he took me to the circus, and I loved that man. And he was so inspiring to me, and it gave me hope. We heard about hope this morning as one of the key things in the process of recovery. Because working in that field, I stopped feeling like a loser. I stopped thinking that this was the worst day of my life, having a drug overdose, that actually I started seeing a path forwards where I could actually work in addiction, I could be a doctor, I could do what I wanted to do, and actually really enjoy it, because I kind of loved working with people. I almost thought about becoming a psychiatrist, but I didn't want to work with people who have really too many mental health issues. So I thought, well, if I work with people with addiction, I work with people who act crazy, and they are crazy when they are using their drugs. But once they get clean and sober, they're not crazy at all. In fact, they're happy and they're healthy and they help other people and they form communities and they're grateful. So I decided to do that. I finished off my family practice residency in Chapel Hill, and then did a fellowship actually here at VCU. And then worked in the field of addiction after that for the last 40 years, mostly specializing in opioid addiction, because that became the big sort of crisis. And during that time, I ended up talking and sharing how the brain works with a lot of different audiences. And so I've been sort of thinking about writing a book for a long time, and I decided when I retired 3 years ago that I would actually do that. And so that's kind of what's led me here. And what I want to do today is just share with you, some of the insights I've gained, give you the best, clearest picture of what opioid addiction is and how it changes the brain, and it makes it obvious that this is a disease. When I first got into recovery, the issue, the question for a lot of people, well, is this really a disease or not? It was obvious to me that it was, because I didn't want to be here. None of my patients ever said, I want to be a drug addict when I grow up. But they fall into it. And as I've gone through this process and I've learned a lot more writing the book, it's helped, sort of shape some of my thoughts and some of my understanding of things. So here's just a few statistics where we still are. Still have a lot of overdose deaths, which is actually decreasing, fortunately. but 10% of the population has the disease of addiction. And relapse with patients who have opioid use disorder when they don't use medication treatment is unfortunately still incredibly high. There are signs of progress. The deaths are going down. There's greater public acceptance of the disease, thanks almost to the opioid crisis, where a lot of people who were quite wealthy or quite influential found that their children and their relatives were also suffering with opioids. It became, a lot more palatable to be able to say this is a disease and people need help for it. So a lot more funding for treatment programs, and even the criminal justice system is starting to embrace treatment. But fentanyl's still everywhere and still very deadly. There's a lot of patterns of drugs that are actually changing since the time I even started writing the book. Alcohol use has started going down with young people. Pot use is more prevalent. And now we're seeing addiction in gaming. We're seeing young people, and I see a table out there even helping people with gaming addiction, because it's basically doing the same thing in the brain. And social media, as we all know, with our scrolling and all that sort of stuff, is very addictive. So there's just a lot more understanding of how addiction works in the brain. And that's kind of what I want to talk about today. So as I wrote the book, I realized it's a lot of complexity for people to try to understand, and I really want the book to be accessible to everybody, because I've written the book as a guidebook so that people can use it to sort of understand what's wrong with them, what the disease really is, how they developed it, how it's changed, and I'm using the word injured, their brain, and then that kind of makes it obvious what to do about it. So I put the book into two sections: part one, the problem; part two, the solutions. And I kept evolving the book over time. I added more patient stories. I kept the chapters short. I used bullet points at the end, and I ended up using graphics. I worked with a VCU grad, Julia Moore, who helped come up with the idea of brains. So we came up with little cartoons for each chapter that help illustrate exactly what's wrong. And so my goal is that if people don't like reading, they can just look at the cartoons and basically get the message for the whole chapter. So this is the chapter, What's Wrong with Me, the first chapter. And I think, hopefully if people can just look at that, they'll get the idea. This is, the sort of text or some of the stuff in the, that is, if you don't look at the cartoon, society believes that, people are weak-willed and all that, but the medical reality is we have an inherited brain disease that's genetics and trauma actually cause the vulnerability, and then the brain becomes physically injured by the drugs, and that becomes obvious why it's a disease, as we'll go on and explain. So one of the first points I wanted to make was that the distinction between the physical dependence is not the same as addiction, because people still get that confused. Most people in this audience are pretty comfortable with that idea that physical dependence is this homeostasis process that happens when somebody takes a drug long enough, their brain adjusts to it, and it becomes physically dependent, and they get withdrawal when they stop, and the brain will eventually go back and not be dependent after a few weeks, although actually post-acute withdrawal probably lasts more like a year or two for things to fully go away. But the disease is different. It happens to 10%. And I saw this a lot in the practice, because we would have people come in and they would say, if you could just detox me and get me off my heroin or off my fentanyl, put an naltrexone implant in me or put me on Vivitrol for 6 months, I will never use again. And they didn't get the idea that the disease hasn't gone away. And so that's why I came up with, in the book, quitting doesn't make the disease go away. So this is the cartoon for that chapter. Because people need to understand that being in recovery for long periods of time hasn't actually made the disease go away. And it becomes obvious as I explain how the brain and how the disease actually develops, why that's true. And the answer is really that the brain has been changed with some of the pathways and the neurotransmitters and things. And that stays there, so that even if people haven't smoked cigarettes for 10, 15 years and then then they decide to have one or two, they very frequently will go back to full-on addiction. And addiction, and opioids and other drugs are certainly the same. And in the book, I tell the story of a San Francisco emergency room physician colleague who got found using fentanyl and was put into a long 5 years of monitoring program. And he did well, and he was feeling good, but he never really bought into the disease. He never really did any support groups. He didn't change anything. And as soon as his 5 years was up, he was back using within a month or two. And it's that kind of story that just make it clearer and clearer that the disease doesn't go away just because people stop using for a while. So how does the brain work? Well, I try to make things simple and just say that there are four parts of the brain that are really important in the brain. The first one is the reward center right in the middle here, the nucleus accumbens it's called, or the ventral tegmental area. And of course we know that this is full of dopamine. And when I ask people in audiences why we would have a pleasure center in our brain, most people say, oh, so that we could be happy. But the reality is we have this dopamine system in our brain to give us survival. So that system gets activated. We release dopamine, have a dopamine spike when we eat food and have sex. Those are essential for survival. Obviously, we need to have strong cravings for it. We need to have strong drives for it. We need to satisfy those needs, or else we don't survive and our species doesn't survive. So that's the first part of the disease that's essential, part of the brain that's essential to understand. The second is the memory circuits, which get activated as soon as we do satisfy those things. So we build very strong memories of a great meal, sexual experiences, but not only for the experience itself, also what I call associated memories. So the associated memories are all the things that happen along with that. And when it comes to drug use, we develop thousands and thousands of these things. And that's not just who you were using with, or what you were doing, or what the music was, or what house it was. It's also the time that you were thinking about it, planning it, getting the money for it, calling up the dealer, meeting with your friends, doing all the other associated things. And when people are using multiple times a day for years at a time, you can see how many associated memories people build up and how strong those memories get. And of course, each of those become triggers. This is the same concept that Pavlov showed with his dogs, where he would ring the bell and give them food. And after a while, he could ring the bell, and the dogs would have associated the bell with the food, so they then had a dopamine release in the brain. Pavlov didn't know that dopamine was going off in their reward system, but it was. And the dogs would salivate and expect. The third part of the brain is the emotion circuits. And it turns out we have two basic emotion circuits. The first one is the falling in love circuits. And we fall in love with food and sex. I mean, there are a lot of food networks. There's a lot of celebrity chefs because we love eating. And we love that stuff. And of course, we fall in love romantically, and we love that stuff. And those are essential. And it's really important that we have this falling in love process so that we can form strong attachments, so that we can raise children and all of that sort of stuff. The problem becomes, of course, that when we take drugs that release more dopamine than our nature ever meant us to get, is that we fall in love with that experience as well. And so it's a little bit like people who have a bad boyfriend or a bad girlfriend. They know it's bad for them, but they love it. They can't stop thinking about him or her. They can't stop thinking about when are we going to see each other. They maybe stalk them. They may be just obsessed with it all day long. And that's exactly the same process that we see with drugs of abuse. The fourth area is the prefrontal cortex, the thinking part of the brain. And of course, that's the part of the brain that puts everything together. So it gets inputs from our reward system. How valuable was this? How much do I like it? Should I do it again now? Should I do it again later? And it also brings up memories. What does this mean? It brings up other context clues. It brings up emotions. And it does all of this so it can then make decisions and apply brakes or say, no, I shouldn't be doing this right now, but also then reevaluate as we do activities and behaviors. This is just a sort of an idea of how much extra dopamine drugs feel so good because they release a much higher amount of dopamine than nature ever meant us to get. As we'll see, the cascade is that, the dopamine spike is so amazing, and the memories get strongly attached, the emotion circuits fall in love, and the prefrontal circuit says, let's do this again. Often now, potato chip effect, so that if I just have 1 or 2 potato chips and I get a dopamine spike from that, and there's another packet or bag there, I'm more likely to actually finish that bag or at least have a lot more. So what causes addiction? Well, bottom line, it's genetics, trauma, and I use the brain bucket analogy that I actually learned from Dr. Danielle Dick, who's one of the geneticists that has worked here at VCU. And the reality is that genetics is still the most important factor. When I first started giving this talk 40 years ago, I thought genetics was really the reason why we call this a disease, is because you inherited it and it's not your fault, and you know, all that sort of stuff. And that is still true, but I've realized that trauma and the drug use itself is actually as important as well. So almost all the patients I saw who came in with a heroin or a fentanyl or an oxy addiction had a family history of alcoholism or addiction. Identical twin studies show clearly that there are a lot of genetic factors in adoption studies. The addiction can skip generations, and I've got a couple of patient stories in the book about patients who came in and grandparents had alcoholism, but the parents didn't drink at all because they didn't want to turn out like their mother and father, and then they still passed on the genes to their children, and they were like, what happened? Where did we go wrong? But it wasn't their fault. They just happened to pass on those genes. The reality, it's a polygenic disease, so it's not one gene that causes this. It's a bit like height. So people aren't either tall or short. There's a lot of genes for being tall or short, and so if you inherit a lot of them, you're tall, and if you inherit not many of them, then you're fairly short. And alcoholism is the same. And that probably also explains why some people have a much more severe disease than another. Some people have an easy disease that's easy to treat. They don't have to work so hard at their recovery, and their relapse rates are lower. In other people, it's much more severe. With my patients, I like using the concept of low dopamine tone. And so the concept there is that what I would say to my patients is probably what some of the genes have caused you to have a slightly low dopamine amount or tone in your brain, and that when you got that dopamine spike, you liked it a lot because you were starting from a slightly depleted amount, and so that made you more likely that you would want to keep doing it and end up getting in trouble with it. It's very helpful for patients to think of it like that and help self-forgiveness so that they can move on. Trauma is the second major thing. Growing up in a dysfunctional alcoholic home causes chronic stress, and this physically changes the developing brain. Children are supposed to be developing these nice pathways of being loved and being nurtured and all that stuff, and when they've got dysfunctional homes, it's exactly the opposite. We still talk about the don't talk, don't trust, don't feel thing that's been around for a long time, but it is what happens in dysfunctional homes. The problem with stress is that it's intermittent. If a parent's got alcoholism or another addiction, sometimes they're loving and they're buying you presents and they're apologizing and saying they'll never do it again, and the next day they're punching the wall and yelling and screaming, and it's chaos. And often it's a social defeat stress, which basically means that people are telling you it's your fault, and if you'd only done this better, we'd be happier here, and that's just so damaging to children. And of course, a lot of this stuff is subconscious. So when we put this together, I love the brain bucket idea. And so the idea is that our brain is like a bucket, and it can get filled up with 3 different things: genetics at the bottom, trauma, and then drug use on top of it. And when the drug use adds to the trauma, the vulnerability, then it starts overflowing and an addiction is developed. And so this is a graphic of that. On the far left, some people are born with a very high genetic predisposition. Doesn't take much drug use to set off the actual addiction. Some people, it's a lot of trauma, PTSD, stuff like that. And most people, 90% of the people, never develop an addiction. They have a little bit of genetics maybe and a little bit of trauma, but they never use enough drugs. What we do see is that some drugs make the bucket overflow quicker. Opioids, cocaine, hard drugs, if you will, pot, probably not quite so quickly. Alcohol, somewhere in the middle there. What ends up happening with the drug use and how it does overflow the bucket is that it starts injuring the brain. When I first couple of versions of the book, I used the word changes, and then I was talking to Linda Hancock, who's very involved with this group, and we started using the word injures, and it's just a better word for what I'm trying to get across, because what ends up happening with the drug use as the bucket's overflowing is that the 4 different parts of the brain all get injured. Now, it's a reversible injury, mostly, because some of the injury stays there, deeply buried, and is, I think, the reason why the disease hasn't really gone away. So I'll go through each of the sections, but basically the reward system, the dopamine starts having less and less effect. You know, and when we first start using drugs, we get a high dopamine spike, and then it starts wearing off. And then the reward system starts getting immune or adjusted to that high dopamine spike. And one of those things that happens means that normal pleasures then lose their value. So, you know, you have people who come into treatment and you start trying to talk to them about, you know, oh, you could do some fun activities, you could visit with friends, you could read a book, you could go for a hike, you could, you know, go to the beach, and they look at you like, why would I bother doing that? Because they're used to a dopamine spike this high, and normal dopamine activities give you a normal amount, and so it's really hard to compete. Fortunately, that recovers over time. The memory circuits become very powerful triggers. As I mentioned earlier, you know, when people use drugs, they create huge numbers of associated memories, and those become stronger and stronger and stronger. One of the things that Pavlov learned with his dogs is he could ring the bell and associate the memory, so the dogs, as soon as they saw the bell or heard the bell, they would know that food was coming. Well, if he extinguished that, basically that means he would ring the bell and not give food. Fairly quickly, the dogs would not assume there was food coming, so they had lost that associated memory. But it wasn't gone completely, because if he then reintroduced the bell and the food later, the dogs would re-remember and learn it, except much faster the second time, because they still kept some of those deep memories deep down, so they learned the response much faster the next time, and it was much slower to extinguish the next time. The emotion circuits, we fall in love with those drugs, and then we also use them to numb our pain. You know, we all have emotions, and in the book I talk about the 4 primary emotions being mad, sad, glad, and afraid. And we have those in order to help us decide what are the best activities or the best actions for us to take. And drugs, of course, provide instant relief for those. 3 of those are negative. Mad, sad, and afraid are all negative emotions, and so none of us like feeling that. And of course, drugs are mood-altering drugs, so they alter those. And that feels really comfortable and easy in the short term, but of course, you know, we haven't solved anything, we just have swept it under the rug. And we start relying on those more and more. The prefrontal cortex develops more and more distorted thinking and our ability to control our actions. So here's a picture of the reward system becoming injured over time. You can see early on high dopamine spikes, but when the dopamine sort of gets used up. So if you picture what's happening in the synapse, the dopamine gets released, but then it gets metabolized, and so there's not quite as much there. So people start going below their baseline. They use a little bit more. The spike isn't quite as high, and then they become more depleted, and eventually they end up falling below the baseline, and they live below the baseline. And so we had so many patients come in to detox off heroin or fentanyl or oxycodone or any of the opioids, and they would say, "Doc, I can't get high anymore. I don't get any buzz at all. I just have to use in order to feel even a little bit." Because not only is the dopamine getting depleted, but also they're physically dependent, which is a depletion of their endorphins. So both systems are getting depleted. The way opioids actually work is that they attach to endorphin receptors, our natural painkiller, and then messages go to the pleasure center and release the dopamine. So both of those get depleted. The associated memories release dopamine, and we've got a picture here of somebody who has not been using for a while, and when they just see someone they used to use with, it actually releases dopamine in the pleasure center. And there are a lot of studies that show that you could put somebody in what's called a PET scanner, and you can actually measure their dopamine going off in real time. And if you show them a picture for an alcoholic, maybe a picture of whiskey or beer or whatever, but if it's a cocaine or a heroin and it's a white powder, they will actually release dopamine in their reward system, and they will get cravings. It's not a choice, it's automatic. They can't stop it, and it's extremely powerful. Probably the most powerful cause of relapse or return to use is these triggers, these associated memories. What's amazing is that this happens subliminally without people even aware of it. So there are studies that show that if you show this white powder for 33 milliseconds, the person will say, "Well, I didn't see anything." They didn't consciously see it, but dopamine still went off in their brain. It's unbelievable. The other thing that happens is when you measure blood flow, you see the dopamine going off in the brain from these associated triggers. Blood flow to the prefrontal cortex, our brakes, saying, "Wait a minute, I probably shouldn't do this, I should make better decisions," actually goes down. And so we see the person getting triggered and wanting more of the dopamine and having less ability to say no and to stop. So this is such a common cause of people relapsing. In the book, I've got a story of a patient, I had a few patients like this, who was doing really well for a year or so, and then they were cleaning out the house. So this particular lady cleaning out her sock drawer, and she found a couple of OxyContin pills. She was using within an hour. What happened was she got dopamine going off in her brain, not her fault. It just happens. She had access to the drug, and it was just automatic. So that's how triggers work. Emotion circuits get numbed by the drug use, and so, obviously these mood-altering drugs numb our moods. And so a big part of recovery then is learning how to deal with our emotions. The prefrontal cortex gets more and more distorted thinking. A lot of times we come into addiction with fairly distorted thinking because we grew up in dysfunctional homes, so we don't have a good handle on what social norms are and things like that. But as the disease progresses, that becomes worse and worse, partly because of the communities, as we heard this morning. We are very social creatures, and so we absorb the social norms and the ideas and the things of everybody around them. But we also shift to immediate gratification, and we also lose hope. So putting this together, there's sort of 3 stages of addiction. Before any use, the brain's vulnerable because of the genetics and trauma. Stage 1, the drug use is still fun, but the brain is being changed and the injuries are developing. Stage 2, the drug use is there to avoid negative feelings, dopamine depletion, people have to use more and more. And physical dependence is developing because of endorphin depletion. And stage 3, is the preoccupation and anticipation. It's just this revolving thing where people need to have a major change to get out of it because their thinking is distorted. They've got these triggers. They have no idea what their risks and what's a good risk, what isn't, what's safe, what isn't. Who are my friends? How do I deal with emotions? They have no real way of dealing with this, and that's the chronic sort of process. And I adapted the Jelinek curve to sort of show that people going down, but also then starting the recovery process. And so when you put it together, addiction's clearly not your fault. Your brain was set up. The drugs cause physical changes in your brain. Accepting that it's not your fault can help you move forward. And I saw this over and over with my patients, and I'm sure we all do. As people have some self-acceptance that it's not their fault, but there is also a path out of this, then it's much easier for them to move on. So I used to emphasize more of the genetics, but now I can see that it's a combination of everything, including the way the brain has been changed by the drugs. So treatment that works, we're going to talk about medications for opioid use disorder, harm reduction, and complete freedom. The bottom line is it's pretty straightforward. You need to stop getting a dopamine spike, and that can be either in a really safe place like an inpatient rehab, a halfway house, without using any medications for opioid use disorder, but even that is somewhat risky when it comes to opioid use disorder. And that allows your brain to stop looking for more and more. It allows the brain to settle down, so then the brain heals, the neurotransmitters can go back to normal, receptors can go back to normal, the brain pathways that have been so strong, those triggers will actually go away. I had a lot of patients who would ask me, so will my triggers ever go away? Will I ever stop having drinking dreams? Will I ever stop having cravings? And when I had about 10 years under my belt, I was like, that sort of started surprising me that people would even ask that. Well, of course they do. And they do. But those deep memories, like Pavlov's dogs, are still there. So if you start hanging around with cigarette smokers and you haven't smoked for 10 years, guess what? You're probably going to start smoking again because those memory pathways are still there. And then it's all about learning how to deal with life. And so one of the first concepts for people who have opioid use disorder is to start thinking, and for the doctor, are they interested in harm reduction or complete freedom? And I wrestled with this a lot in the book because, I love people being off everything, but the reality is that if people don't use medications for opioid use disorder, they have a very low success rate. Well then, how do we deal with the reality that a lot of people who are going to methadone clinics, going to Suboxone clinics, are still drinking on the weekends, they're still smoking pot, they're still hanging around with other using friends. And so I realized I needed to put in the book, that some people, harm reduction is exactly where they should be. We shouldn't be kicking people out of treatment programs because they get high on the weekends, even if they're using opioids, even if they're using cocaine. We can't help people if they don't keep coming back to treatment. We certainly can't help them if they overdose and die because we kicked them out and now their tolerance is low and they've overdosed. But I still love complete freedom, and so that's, people who are taking their medication for opioid use disorder but are not using opioids and other drugs. The goal is the full brain healing, emotional growth, and the most fulfilling life. And in some ways, this is a little bit like doctors who are treating patients with depression. Of course, when people have depression and we put them on SSRIs or other medications for bipolar, whatever, we would like them to not be using drugs. We would like them to be going to counseling. We would like them to be in support groups or helping. But the reality is we still treat those people and we try moving them forwards along that recovery path. So I don't want to spend too much time because most people will already know this. We have methadone, which is the most supportive because you have to go. Even if you use, you're not going to go into withdrawal. It protects you from an overdose. Very good for high-risk patients needing a lot of structure. Suboxone is much more accessible. Buprenorphine, it's very convenient. Long-acting versions of Sublocade and Brixadi are now available, and I don't have time to talk about why they work so well, but they are unbelievable. And I think the future of medications for opioid use disorder is going to include a lot more of those, because they take away even more of the dopamine spike, and they take away people's cravings because or obsessions about it, because they're getting a shot once a month, so they stop thinking. One of the realities of people taking methadone or buprenorphine is they still think about it a lot. They still think, am I getting enough? Am I getting too much? Should I be? Did I not sleep? I'm still anxious. I'm still, maybe I should go up on the dose. Maybe I should not. And that is part of the addiction process, is that thinking about it, that obsessing about it. And long-acting versions, when you just get a shot once a month, just eliminate that. And I've had so many people tell me that as soon as they got on it, they just felt so much better. Vivitrol, which we used a lot of in my practice, is really good, but it's really the best for committed patients because when it wears off, people have a high risk of an overdose and dying. And so they need to be very committed to working a completely abstinent, drug-free program. So I used to turn people away from the clinic if they weren't committed to going to treatment and staying abstinent from alcohol, pot, and from everything. It is a really good step down, so I recommend that if people are on methadone or Suboxone and they're ready to stop using them, then Vivitrol and then even oral naltrexone can be a great sort of step down. Turns out that oral naltrexone, everybody's familiar with naltrexone, is the opioid blocker, so it goes to the endorphin receptors and blocks it so people can't get high. And it works really well with this 1 month injection because of what I just said with the other drugs. It gives you that whole month where you can't even think about it. I can't get high, so I'm not even going to think about it. The cravings go away and they feel great. Oral naltrexone just lasts 1 day, and so I had a lot of patients who would tell me, I tried that oral naltrexone and it actually increased my cravings, because every time I went to take the pill, my brain would be thinking, you don't have to take it, you could get high today, but if you do take it, you could get high tomorrow. And everybody can wait 24 hours to get high. I mean, that's easy, right? So it actually increased cravings. It made them think about it more. So oral naltrexone can be useful after you've got a lot of recovery under your belt. I recommend that people who are on medications for opioid use disorder claim a sobriety date, just like people who are completely abstinent. And there's 3 criteria that I tell people. 1, you're taking your medication as prescribed. You're not abusing it, you're not taking more. If you need to go up on the dose, you get clearance with your doctor, your nurse practitioner first. You're not using any other drugs, no alcohol, pot, anything else, so you are abstinent. And you're working on an emotional and maybe an emotional spiritual growth path, so that you're working to actually improve things. And if you're doing those 3 things, you're in recovery. You can claim a recovery date. You can tell people, I've been in recovery since January the 3rd. If you slip up, get a new recovery date. It's no different than people with alcohol use disorder or something like that. MOUDs are very safe long-term. There's no hurry to stop. Decisions should be made with a team. So I strongly recommend that you use your trusted advisors and your substance abuse professional. So lastly, we'll just talk about, in the second part of the book, I've got a lot of the recovery steps. And the first step is asking for help. As we heard this morning, it's almost impossible to recover alone. Asking for help is a sign of strength. First, acknowledge it. I strongly recommend that people consult an addiction medicine specialist who can actually get a full evaluation, figure out exactly what the problem is, how bad the problem, are there any other mental health issues that need to be addressed, are there any other, and then come up with a recovery plan, just like a cancer doctor does. If you have cancer of the throat, you don't just go see a radiation therapist. You don't just go see a surgeon. You go see an oncologist who can then evaluate, figure what's going on, how bad is it, what's your chance of success, what's your most likely best path forward, and then you develop a recovery plan. I believe that opioid use disorder and all addiction should be the same. the best thing is to go see an addiction medicine specialist who can do that thorough evaluation and then come up with a recovery plan. And then it's the patient's job to buy into that, to understand that, to make sure that they do it. And of course, that's then an ongoing relationship because we know this is a chronic relapsing disease. And so if there's hiccups or there's problems on the road, then you can work on that together. That includes getting your team of such trusted advisors, and that can include people in your support group. It can be a therapist, a recovery coach, all sorts of things. The first 90 days is the most critical period, and that includes stabilizing, stopping the drugs, usually starting an MOUD, figuring out part of the recovery plan is where am I going to live? How am I going to deal with transport? How am I going to deal with that? Education, professional treatment, either inpatient or IOP or even individual therapy, although that's not so good in the early days, is incredibly valuable. And then building up your connections, and then breaking habits and new things. So recovery is a journey, and so there are some distinct stages that people go through. I put in the book 12 factors that I found that predict recovery success. I know we're running out of time pretty soon. But understanding the disease, as we've talked about this morning, I think once you understand what's happened, how it developed, it becomes much more clear what to do about it. Accepting it is obviously important, abstaining from all mood-altering drugs. A lot of people don't have much motivation to change, but that can change and that can be worked on. Taking action, not just talking about it, is obviously important. The severity of the disease is part of what we talked about with the genetics and also the environment. We need to make sure the living environment's safe. Co-occurring mental health issues need to be treated. Recovery skills can be worked on and built on. And having a passion and a sense of purpose, I think, is incredibly important. So that's certainly what helped me, and I see that happen all the time with people who basically replace what gives them pleasure and gives them a sense of purpose. Because when people are using drugs and alcohol, getting high and using is their passion and their purpose, and they need to replace that. So some of the recovery skills that I talk about in the book is building up recovery capital, like we heard about this morning. And for me, everything that you do that is moving you forwards in recovery adds to that. That includes length of sobriety. Calling your sponsor, going to a meeting, reading a book, watching a recovery movie, hanging out with sober friends. All of these things move you another step away from a return to use. Identifying and dealing with your emotions is key. Learning how to communicate effectively. Recovering from childhood trauma is often the hardest work, but can also be essential for people to forgive themselves and move on. Developing connections and avoiding loneliness, like we heard about. Spirituality is an important part of it, and finding that purpose and passion. I'm not an expert on families and how to deal with it, but I did put a chapter in there, and I was lucky enough to meet with Shelley Young and Kathy Wren, who I think is speaking this afternoon, who helped me formulate a chapter for the families, because I think the book can be really helpful for families to learn about what's going on with their loved ones and then know what to do about it. And I think most people here probably know all of this stuff, that it's the person who has the disease, it's their responsibility to deal with it. An advisor once said, never work harder on someone else's recovery than they're working on it themselves. And it's a little bit trite, but it's a lot of truth to it, wisdom underneath that. It's their responsibility. And it's the family member's responsibility to deal with their own health. And a lot of people get stuck thinking that if my loved one just got better, all my problems would go away and I'd be happy. And unfortunately, life isn't quite that simple. So in summary, it's a brain disease. It's not a moral failing. Genetics and trauma set it up. The brain can heal. MOUDs are incredibly helpful. And that's it. Thank you very much.
Great. We have time for a couple of questions. Got one in the back.
From a personal standpoint, I have a daughter who's been on methadone for over 15 years. And she has been, first she got on it because her her doctor said, that's what you have to do. So about a year into it, my son died of an overdose. And then about a year after that, she got in a horrible car wreck where she had to be revived several times and had 38 surgeries, et cetera, et cetera. Her body's so broken. And she's been on this for pain management now rather than addiction treatment. And she has tried to get off of it multiple times, and they will decrease the dose, and then they say, well, now you need an increase because your blood pressure is too high. The bottom line of this question is, if you're in a treatment center, a treatment clinic or whatever, that just won't take you off. She wants off. I mean, the long-term effects we know and we see in her, and she can't get into pain management because it takes 30 days of complete abstinence before they'll even see you. So do you have any ideas about that kind of a situation? I'm sure she's not the only one.
Yeah, thanks for the question. It's a complex situation, and I think my thoughts, my advice would be to have her see an addiction medicine specialist as a second opinion. Because someone outside of that, someone's been treating her and that's sort of working, keeping her safe and all that sort of stuff. And it's a complex decision about how you then deal with an addiction, chronic pain, withdrawal. All of those things by themselves are complex. But having an independent person look at the situation new and come up with a plan that makes sense, I think can then work. Because detox is possible. I used to detox people off methadone all the time. We actually developed a quick detox, and we'd get people off in 10 days. And they did well. And interestingly, chronic pain, 99% of them, maybe all of them, said their pain was less after we got them off the opioids because of another issue called opioid-induced hyperalgesia. And so it certainly can be done. The question is, should it be done? Because, that's a complex, because what's working is sort of working right now. So, you don't want to jump out of the frying pan and end up with more trouble. But I think an independent person is the right person to do that. And you would do that with any other disease. So I think it's time to start doing that with opioid addiction or any addiction. Is like, let's have a specialist whose job is to know what the best treatment plan is by doing a thorough assessment and then coming up with a treatment plan that we will execute on.
Thank you, Doc. Do you still offer rapid detox?
The clinic that I started is still operating, yes, and they're doing that and also treating alcohol detox, yes.
Have you done any study on ibogaine? I hope I'm saying that right.
I haven't done any study on
it.
ibogaine. It's another whole subject, psychedelics, and I've actually got a little bit at the back of my book that I've added of future developments because, psychedelics are they're an interesting thing in itself. I did see a couple of people who dramatically lost cravings because of an ibogaine experience, but they didn't do any changing, and so their brain pathways were still there, and they relapsed and went back to using quickly. So again, it's an interesting piece of the puzzle, and I think in the future we'll know a lot more about it and how to integrate that sort of thing. Because one of the interesting things for me personally is the process of recovery often is a moment of clarity where suddenly you realize, wow, I don't need to be like that anymore. I could be like this. This is a pathway. And that happened to me in rehab. And ibogaine and other psychedelics can sometimes induce that, but it needs to be followed up with other stuff, in my opinion. Yeah.
All right. Thank you so much, Peter.
Thank you.